Hello there, folks, and welcome to the Jefferson Educational Society's Global Summit 12 presentation of the Global Coronavirus Pandemic and America's Path Forward. I'm Ben Spigot. I'm the Vice President at the JES. In this program, which originally aired live on Tuesday, May 18th, 2021, Dr. Michael Saag, Director of Infectious Disease at the University of Alabama, Birmingham, offers insight into the COVID-19 pandemic, where we've been, where we are, and where we might head. And then JES Global Summit Chairman Steve Scully interviews him. Before we get to the program, I'd like to thank all of our event sponsors: Erie Insurance, Erie News Now, the Erie County Gaming Revenue Authority, WQLN Public Media, and the American Tapestry Project, and our Global Summit event partner, the City Club of Cleveland. And I'd like to remind you that you can access additional programs to stream on demand at jeserie.org, where you'll also find a wide range of publications, from reports, essays, timely writings, and more. And be sure to like us on Facebook, follow us on Twitter and Instagram, and subscribe to our YouTube channel to stay up to date on all JES content. And now, here's the global coronavirus pandemic and America's path forward.
Hey, Ben, thank you so much. I am excited about every night, but I'm really excited about tonight. I've done a lot of interviews over the last 15 months dealing with COVID-19, but I've got to tell you, I've not come across anyone who does a better job distilling where we were, where we are, and where we're going than Dr. Michael Saag. As you indicated, he's joining us from Birmingham, Alabama. A lot of synergy between Birmingham and Erie, Pennsylvania, industrial towns, mid-sized cities, both communities that have dealt with a lot of history in their past and certainly a promising future. He is a graduate of Tulane University and earned his medical degree from the University of Louisville. In addition to his expertise on infectious diseases, he's also one of the world's leaders when it comes to HIV and AIDS research. And I want to follow up on your point, Ben, in terms of questions. If you have questions even early on, Dr. Saag is going to give a presentation. About midway through, he's just going to take a pause. If there are questions, I'll incorporate them, and then he'll continue. And then during the second half of the program, more of your questions and my follow-ups as well. So let me welcome Dr. Michael Saag on behalf of the Jefferson Educational Society in Erie. It's a thrill and an honor to have you here. So much to talk about. And thank you for giving up some of your time on this Tuesday to share your expertise with the residents of Northwest Pennsylvania.
Well, it's a real pleasure to be here, and thanks so much for the invitation. I'll just jump right in and we'll get going with this, and I'm going to share my screen, and I will stop as we talked about midway to just make sure we capture all the things. Can you see this okay? Yep. Okay.
Indeed, yes. Yes, yeah. We can.
So I'm going to start with Pigpen, Peanut's character, who, if you notice, has this cloud around him. And to me, this epitomizes what happens when somebody gets sick when they're infected with COVID, because move that cloud up to around his head. And that's what's happening as he breathes, that this COVID virus is going into the environment around him. And if he's talking, it goes a little further out. If he's screaming, it goes further. If he's singing, further. And this is why this virus is so contagious. It's because these respiratory small droplets go into the air. And if you can imagine, if you're in a closed space with someone who's infected and you're close within 3 feet and you're there for more than 10 or so minutes, you're going to be breathing in that virus and your chance of infection is quite high. So when people say, well, wait a minute, I don't like masks, I don't think they do anything. Well, that's frankly just wrong, because you can look at this picture and imagine, not even so much for you, if you have your mask on, yes, that might help filter the air a little bit, but where it really has impact, in this case, if the patient, in this case, Pigpen, had a mask on, it reduces that cloud around them up to 90%, and therefore makes it safer. And remember, a lot of times people are infected with COVID, and then the day or two before they get sick, they're transmitting virus. So just knowing if somebody has a fever or they don't feel well, that's a little bit late in the game. The transmission happens before them. This is another important concept. We talked about the mask and we talked about transmission in a small environment. This is also an important point about crowd size. So let me walk you through this a little bit. If we have an event, let's say with 10 people, in this little light gray bar, let's go to Alabama this was roughly about October. If we had 10 people in a room together, there's a 40% likelihood at that moment that one of the 10 people would be infected with COVID. If we had 25 in the slightly more shaded bar, 25 people in the room together, the chance that one out of that 25 was infected is over 72%. If 50 people were in the room, then it would be 92% that one out of the 50 people would be infected. And if there were 100 people in the event, then almost 100% that at least one person. So now when you think back to the summer, when people were gathering in large venues, it might have been church, it might have been even a political rally. When those folks were crowded together, there was a lot of transmission that happened. And then they go home, they transmit it at home. And this is what led to a lot of our surges or spikes, whatever you want to call it. Notice, though, when the rate of infection drops, like in this case, Vermont was not hit too hard, then even with 100 people, there's only about a 25, 30% chance. So it matters what the environment is around us in terms of that likelihood. Nowadays, fortunately, as I'll show you here, we are in pretty good shape. We're now down to, I guess, roughly about 35,000 new cases a day. Compare that to over 250,000 cases a day that we were experiencing back just after New Year's, and it was horrible. I walked through my hospital and was literally almost brought to tears looking at the usual units that I attend on, and every single room was COVID, every single one. And it was such an overwhelming feeling to go through that. And I can't express the power of that emotionally for me. And I know all of you have been touched in Erie and Pennsylvania, around the country, around the world. We have been devastated by the consequences. And I'm sure that there's likely one or two, or unfortunately more of you, who might well have lost a relative to this pandemic. And my heart goes out to you, because it's a really a terrible thing for the patient to go through, but also the family. Now, I will notice, though, with this decrease here that we're seeing right around February, well, what was that? That's the vaccine. That's the vaccine kicking in. And we're going to talk about that in a minute. Contrast this with India. Now, I'm going to orient you. This is case numbers over here. And if you look carefully, less than 2 months ago, they had fewer cases than the United States did. And then there was an event. There was a religious gathering at the Ganges River. And literally well over 1 million, I don't know the exact number, crowded together and experienced this cultural and religious and very meaningful ceremony, but it became the ultimate super spreader event. And people went there and came back on trains, and the virus was transmitted to a large degree, and this is the consequence. At that moment, they only had about 1% to 2% of the population who were vaccinated, so not nearly anything close to make a dent. And this is what they've gone through, and it is devastating. They've had hospitals that ran out of oxygen, and I can't imagine trying to take care of a person with COVID without oxygen. That's our mainstay of keeping people alive, and they didn't have that, and their death rates are astronomical. They're coming out of it now, but it's taken a while, and it's been a horrible thing, of course, for them. So what's different? Why do you think that so many more people in India got infected at that one event? It seems like it was a more virulent, or at least a more infectious strain, and indeed it is. What we're looking at here is the emergence of these different variants, and it's not important to remember the numbers or the names. What is important is to watch, for example, this is the Great Britain strain, B117, and notice how it's taking over in terms, this is just in the United States, this is how it's taking over in our country. Why does it matter? Because that strain is probably about twice as infectious as the original strain that we got back in February and March of 2020. So what does that mean? That if you're in the room with Pigpen and Pigpen's infected, it might not be a 15-minute exposure that would lead to infection. It might just be a 5 or 8-minute exposure, much more infectious. And we're also learning that a lot of these variants, including the British one, is more virulent. And what that means is it causes worse disease. So why are we not seeing, with these variants emerging, this spike in cases like we had back in January? The vaccine. That's simple. And fortunately, right now, the vaccine covers all of the known variants that are in the United States, maybe not quite as efficiently one to the other versus the original virus in terms of just protection against infection. But when infection happens, it's much less disease, much more attenuated infection, so that the person who is infected either doesn't have symptoms at all once they've been vaccinated or has mild symptoms, doesn't go to the hospital, and certainly doesn't die. So that's what the vaccine does for us. Here's some important data just in the last couple of months. And what I want you to notice, the majority of people who are getting infected in today's world in the United States are young people. Yeah, young people. And notice those over the age of 65, which was a predominant factor a year ago, now their numbers are going down, but they still represent the largest number of deaths and hospitalization, even though their overall numbers are smaller. So one of the questions we get is, why aren't we just going to vaccinate the older folks and leave the young people alone? Answer is very simple, because the young people are a reservoir of continuing infection. And if we're going to snuff this thing out like we all want to do and get back to normal, everyone's got to get vaccinated. And the great news over the last couple of weeks, the Pfizer vaccine proved safe and effective for people age 12 and over. So let's get everybody vaccinated. And I'll talk about the safety here in just a minute. So this is a great place, Steve, to pause and see what kind of questions we have, because I'll spend the second half of the talk talking about a vaccine.
Thank you, Dr. Saag. One of the questions, and you alluded to this just a moment ago, but how concerned should we be about potentially new variants that we're not yet familiar with and the effectiveness of the vaccine?
Great. And that's more than a hypothetical. I think it's likely, if not expected, that viral variants are continuing to emerge. And it's especially going to be coming from hotspot areas, for example, India. And we live in a global community, right? We travel. We're hopefully going to travel even more as things get better. But it's pretty easy if you're in another location, even if you're vaccinated, you could be transiently infected, inadvertently bring it back to the United States. And the unvaccinated folks among us, especially as we let the mask down, they're going to get infected with one of these variants, and then it might start spreading. So we need to be careful. So how do we do it? Vaccinate everyone. I cannot say that enough. Vaccinate everyone. I know there's hesitancy. I know people don't want to do it, but it's our way out. It's our ticket to ride. And I'll finish this comment by saying, we don't fully appreciate how lucky, and I'm going to underscore that word, we are that these vaccines worked. I've been in AIDS research for 37 years. We've been working on a vaccine for 37 years. We don't have an HIV vaccine. We worked on this vaccine for 10 months. And not only did it work spectacularly well with 95% efficacy and a remarkably safe safety profile. We are lucky. So for those of you who ever wondered, gosh, what would it be like to live in biblical times and witness a miracle? The vaccine was a miracle in our lifetime.
Another question from a resident of Erie, Pennsylvania. As you know, Erie is cold in the winter. Season is prominent in the northern part of the country. It is across the country. So are we now looking at vaccines for the flu and for COVID moving forward?
Yeah, I think we are. And whether they'll be given together, I kind of doubt that, at least not for this upcoming season. But I think, as I'll show you in a minute, I think the immunity from the vaccine likely will start to wane a little bit after a year. We'll only know a year after the vaccines were given. And we should expect a booster shot, just one, not the two, just one shot. And that'll probably be around early winter. So I think we'll get our flu shot at the usual time, let's say September, October, and then maybe into January, we'll start vaccinating. It'll be much better this time because there'll be plenty of vaccine to go around. It won't be hard to get. You won't be scrambling to drive into Cleveland or some other place to get your vaccine, like I know a lot of you did back in January. It's going to be easy to get, and you'll get it from your local doctor or the pharmacy or maybe Walmart, but we'll have it readily available.
One final question, then we'll go back to the second half of your presentation, Dr. Saag. This is a question from an Erie resident who wonders whether the CDC may have jumped the gun on the issue of no need to wear a mask. We should point out that today we learned from the CDC that 60% of Americans have had at least one COVID vaccine.
That's a great segue back to the talk, because I'm going to hit that question head on.
Perfect.
At the very end of the talk. So thanks.
We knew
that. Great segue. It's like we worked on this in advance.
There
Great.
you go.
Here we go. So we have these three vaccines, Pfizer, Moderna, and J&J. And as you know, the Pfizer and Moderna used a new technology that we've never used before called mRNA. Now, what that is it's a strand of RNA, very small genetic material, not even nearly close to what the virus looks like, and just a small fragment of that outer protein, the spike, where it gets its name crown, a little spike that's important for binding the virus to the airways. This little spike protein, mRNA, is shuttled in there. We inject it in the arm. It expresses for maybe a couple hours, 6, 8, 10 hours. And as it does, the immune system gets a game plan. It says, look at this, reacts to it, shuts it down, and then has memory of what it saw. So if you, as a vaccinated person, encounter that spike protein, you've already got an immediate immune response. You've got antibody pre-existing, and it protects you from getting infected in the first place for the most part. But even if you got infected, as I said earlier, you will not have a very significant clinical illness. The J&J is out of a different thing altogether. It's a vector, which means it's another virus that's not infectious to humans, called an adenovirus. It's actually an adenovirus that infects chimpanzees, but not humans. And there, that same spike protein part is inserted in there. When the virus gets expressed in the human cell, it produces that spike protein, the immunity responds. So here, I'm going to have all of you be a statistician with me real quick. These are the data from the original Pfizer study, 40,000 people, 20,000 in each arm. And what we're looking at here is time point 0 is the first shot, and out here is when the people got the second shot. But if you look really carefully, it was about the red line is the vaccine recipients, blue line are the placebo. And what this is the relative number of people who developed symptomatic COVID over the 3 to 4 months that the trial went on. And notice at about day 13, before they get their second shot, there starts the divergence of the curves. And that continues. Here's a second shot here, and it's pretty striking that you get this 95% reduction in infection, symptomatic infection, from those two shots in the case of the Pfizer vaccine, and the same for the Moderna. Now, those of you who are well-versed in statistics would say, wait a minute, you could, with this type of outcome, you could have shown this with a couple, 300 people in each arm, and you would have gotten your answer correct if we were only looking for efficacy. But we were also looking for safety. And to get a good safety read, you need thousands, tens of thousands of people to get the vaccine. And that's what we did. And that's why I'm so proud of the scientific community for their effort, because they pulled this off impeccably well. And for those of us who are a little bit suspect of government, I get it. But there are certain things the government does well by us. One is we got on an airplane, FAA keeps planes from running into one another in midair. The FDA does its job in applying rigor to the review process, making sure safety is there and efficacy is there. And I'll get to this in a minute with the J&J story, but they also do surveillance for us, watching out to see if there's anything unexpected and then alerting us when it happens. As far as side effects, they're pretty much comparable. Here I show a comparison. You can just on your own look up and down, but here's the Pfizer vaccine. And like most vaccines, it's mostly local pain at the injection site, some redness, some swelling, maybe a rash. The systemic effects, meaning usually happens on somebody who didn't have infection on the second shot. Muscle aches, fatigue is pretty common, headache, chills. Some people get fever, not many. And compare that to Shingrix, which is the HPV which is the chickenpox virus that prevents against shingles. A little bit more systemic effect there because there's an adjuvant, which means an immune stimulator that's in there that brings on a little bit more symptoms. But less side effects with the flu vaccine than we see with the COVID vaccine, but I think that's tolerable. Let me pause for a second and say this. A lot of people say, should I get the COVID vaccine, yes or no? As if it's a dichotomous decision. I'm going to get the vaccine or I'm not. That's not the comparison. The comparison is, am I going to get the vaccine and take the risk of the vaccine versus I'm going to keep myself vulnerable to getting COVID infection and take my chances with the side effects of that? There's no comparison. This vaccine is remarkably safe, and so far down to 12-year-olds. And I think we're going to see sometime in the summer that 5 to 12-year-olds will be approved. And ultimately, by the end of the year, any child over 6 months will be eligible for the vaccine. And that's when we'll get our foothold against this. This is where we are. Actually, I've updated this. The date's wrong over here in the corner, but you see it's variable. Moving up to Pennsylvania, it's covered up here. Hold on. Yeah, here we are. And you can see that you guys are doing okay, better than Alabama in general. And the country is Steve said earlier, is at about at 60%. In Alabama, we're only about 37 to 40%. We've got a ways to go. And then this is a little bit concerning. So here, a lot of us were clamoring, right, for the vaccine, nothing available. Now the production kicks up to 2 to 3 million, almost 4 million doses produced a day. And then the uptick continues. And then mid-May, it seems like we saturated the people who really wanted it. And now we're seeing a downtick, but we're still getting 1 to 2 million people vaccinated a day, which is pretty good. We need to continue that. I'm going to talk about something real quick called herd immunity. I'll preface by giving you my punchline. I'm tired of hearing about herd immunity. I've, pun intended, heard enough. And the reason for that is that it's complicated. And the punchline here is that let's stop talking about herd immunity and just get everybody vaccinated. I guarantee you that will solve our problem. But if we want to talk about it in general terms, to orient you, the number of susceptible people are here in blue, and that those who are infectious are in the red, and then the recovered are in gold. So when we use that, we're going to look for something called R0 or R0, which is the relative infectivity. And this virus is about 4, which is pretty infectious. And then that determines the number of people that we need to protect. And here it's about 75% when the R0 is 4. So here's the graphic. You got an infected person here in red, and everyone around them is susceptible. That's the worst situation. Now, this person becomes recovered, but he spread it to these other 3, and now they're spreading it to others. Think India last month. But then once enough people get infected, ultimately, they are no longer susceptible, at least for a short period of time, for about 6 to 8 months. And the infection theoretically could burn out. When you get to this situation, now these again in gold are the people who've already had it and have some immunity or maybe got a vaccine. The infected person only really has one way out to this to distribute the virus to someone. And ultimately, you get to a situation where there are very few people susceptible and the entire infection takes itself out. Here's the problem. This is not a static situation. The immunity from initial infection wanes at about 6 to 8 months. So yeah, you had COVID, let's say back in September, your immunity's starting to go away now, and you're going to be susceptible to another infection. The vaccine will kick your immunity up to the stratosphere. And interestingly, the immunity delivered by the vaccine is much stronger than the immunity driven by getting infected itself. But even that immunity, as we just alluded to with the need for boosters, will start to wane over some time. And so we'll probably need boosters to keep a situation where the majority of people are not infectious. So because that dynamic is changing, let's just get away from the concept of herd immunity and just talk about vaccinating people. And here we are. This is how we're vaccinating now. This is back to May 3rd. And we're going to probably, at the rate we are, have most people in the United States by the time school starts, we'll have 75 to 80%. And I hope we do better than that. One of the things, and I'm going to dive into a little bit of biology here briefly. And what I'm trying to show you is that this is a person who's infected. And immediately after infection, the virus spikes to about day 4 or 5 or 6, and then comes down because the immune system starts to recognize it and shuts it down. And this is in the normal situation. And the thing to keep in mind, it's more than antibody. Initially, there's something called the innate immune response, which is how our shock troops that go in, the first responders, and they attack that thing. And then after that, the so-called responsive immune response, the immune response that's more antibody driven, that adaptive immune response, that is where you get antibody production and you get T cells. The reason I bring this up, a lot of people are on immunosuppressive agents like Rituxan that shuts down antibody production. They say, oh, I'm not going to get protection. Well, that's not completely true, because your vaccine will stimulate your T cells. And so you'll get that part of the immune system working for you. Real quickly through J&J, and then I'm going to close up. This is where our government did a great job. The J&J ramped up in a big way towards the end of March, where over half of the people that got a J&J vaccine got it in about a 10-day period. And they saw 5 or 6 cases of this very peculiar central venous thrombosis occur. That's a clot in one of the major venous systems around the brain, highly unusual. And they discovered that the platelet count would drop along with it. Very rare. We see it sometimes when people get heparin, and it's called heparin-induced thrombocytopenia, also associated with clots, and it was the exact same mechanism. And just like that, they figured this out at the FDA working with scientists, and they put a pause because they knew that a huge number of people got vaccinated in the last 10 days. They had 5 or 6 reports. They're not going to continue doing that unabated. They're going to stop, pause, take a look, and see what the real numbers are. And that's what they did. And this is what these are right from the FDA presentation a few weeks ago, actually a month ago, on April 21st. And you'll notice that almost all the cases occurred in young women. At that time, there were no men. Now there's, I think, 1, but few numbers, 13 out of almost 2 million. And that is not a large number at all, but it is a number. And so my take-home point from this isn't their conclusion necessarily. My take-home point, if I'm a woman between the age of 18 and 50, and I have a choice of vaccines, I'm probably going to take Pfizer or Moderna. And I think for everybody else, it's safe, I would argue, at least based on the data we have so far, to do J&J. And the advantage of J&J vaccine, not only does it work, it's safe otherwise, except for these rare events, and it's only 1 shot. And I'll spare you this. I'm just going to jump ahead, but I think that was a take-home message. So here's a common question. What do I do after vaccines? It gets to that last question. So we continue to wear a mask in public. Well, if we know we're around a bunch of other vaccinated people and we're confident of that, don't need a mask, indoors or outdoors. New guidance. But how do you know? How do you know who's been vaccinated? And so I think it's safer for all of us to do this. I will add, I just got off the phone with a colleague of mine about an hour ago. We were both commenting about, we didn't see any influenza this season, hardly any. I didn't see a single case, not one. Respiratory syncytial virus, the number 1 cause of hospital admissions, but kids between the ages of 2 and 5 hardly saw it the entire winter. That's partly because we were locked down. We don't want to go through that again, but masks made a difference. So I'm seriously considering just wearing a mask through a lot of this coming winter, just because I don't want to get this other stuff. I didn't have a cold all season. That's unusual for me. Keeping social distance, large crowds, we've already talked about that. Traveling, if you're vaccinated, is okay. Still wear masks on planes. Masks are not necessary. I wrote this slide about 2 weeks ago, and the CDC kind of came and validated what I'm saying here. And that is for small gatherings of people known to be fully vaccinated. So this could be your family, a bridge group, small religious service. I'm not sure we're ready for big yet, but everyone's clamoring to get back. And this is the CDC's document or new updated version. And what you're looking at here is unvaccinated people vaccinated. I'm not going to pay too much attention to the unvaccinated. They're going to need to continue to wear masks for most everything. But the take-home point here is if you're around other fully vaccinated people, indoors or outdoors, you don't need a mask. And I agree with that. But the operative phrase here, fully vaccinated people. And what I'm seeing happening right now is that a lot of the people on this side of the ledger, unvaccinated folks, they're jumping right in there with both feet and saying, hey, CDC said I can go and do whatever I want to do. Nope. That's not what the CDC said. The CDC said, if you're vaccinated, you've got a ticket to ride. If you're vaccinated, you've got liberty. You've got the freedom to go do your normal activities, especially when you're around other vaccinated people. So I'm going to stop there and turn back, Steve, to you, and we'll have Q&A for the rest of the time.
Well, like I said, and you didn't let us down, nobody does a better job explaining this than you, and what a treat for the people of Erie. So thank you very much, Dr. Saag. I have 3 very specific questions, one broader question that you can take more time on, and then we'll get questions from those who are watching. But I want to follow up on the issue of masks, because if you travel to Japan, South Korea, China, they've been wearing masks for years. Mm-hmm. What do they know that we now have learned over this last year?
Yeah, and I remember a lot of people I travel with were making fun of people in the Asian communities because they wore masks. But guess what? They went through SARS-1 back in 2003. And I'm not sure that tradition started exactly then, but they got hit with this. And if you look carefully at the data, the Asian Rim hardly had any COVID, hardly had any. Singapore, Taiwan, South Korea, Japan had a little spike here and there. Even China, after they had some pretty draconian measures, but they got it under control pretty quick. Australia, hardly any cases. New Zealand, almost zero. And it's because they went through this before and they knew what to do and they learned their lesson. Hopefully, we as a country will learn our lesson. But for me, wearing a mask is not really a statement of anything, except I'm just trying to keep myself from getting sick. In a bad flu season or RSV season or other things, I'm pulling my mask out again.
So you think a mask is going to be the new norm moving ahead for you personally and for many Americans?
I think for a lot of people, what we need to do is get away from the politicalization of it, for goodness sakes. I mean, come on. This is a public health thing. This is not a statement of what political party I'm aligned with or not aligned with. This is just public health. And I think we were really we were a disservice to ourselves by engaging in political rhetoric around a public health crisis. Well, anthropologists and historians will talk for decades about how we did ourselves in. And unfortunately, I think tens of thousands, if not more than 100,000 people died because of our inability to get our act together.
And a Wall Street Journal poll saying that 41% of Republicans don't want to refuse to get the COVID-19 shot. So it is political, but we don't want to go there. But you're right. It's become like everything else in our country. Second specific question is, why do you lose taste? And I mentioned that because the governor of Virginia had COVID-19 and 4 months later, he still can't taste anything. What is it about this virus for many people that they lose their sense of taste and lose it for a long period of time?
Right. So I had COVID March of 2020 early, like one of the first people in Alabama long story. I'll spare you the details, but I lost my sense of taste and smell. It came back after about 6 to 8 weeks. What happens biologically? The nerve that transmits the sense of smell is like every other nerve. Around it has a structure that feeds it, get blood supply and other things. And the cells that provide that sheath, that lining, gets infected with COVID, and it causes dysfunction of the nerve for a period of time until that sheath can regenerate. And when that sheath regenerates, typically the smell comes back, although not always. And the loss of taste is really a function of smell. If you've lost your sense of smell, you can't taste well. I mean, talk to anyone who might have lost their smell. They can't tell a difference between wine because the discriminating ability to taste Pinot from a cab is really in the smell as much as it is in the mouth.
How are you today? How do you feel? And how's your sense of taste and smell?
Sense of taste and smell is back. And I did have, unfortunately for me, had some hearing loss, which is a little unusual with my COVID episode, and that hadn't quite come back. So I'm wearing hearing aids now. I'm doing okay, but it's a setback. Other people aren't, as I'll use the word, fortunate as I am, and there's something called long COVID or a PASC, P-A-S-C, and that's where symptoms of COVID last well beyond 2 months or so. And it can be fatigue almost for everyone, but headaches or brain fog or shortness of breath or something really awful, which is a fast heart rate just with a simple activity. So I've seen marathon runners who just walking to the mailbox, their heart rate spikes to 150, and it's debilitating. So nobody wants to get COVID. And so for the 41% of people, Republican or Democrat, who don't want to get vaccinated, think again, gently, think again about whether you want to put yourself at risk for all this stuff that is preventable with a vaccine.
My third specific question, then I'll weave in some of the questions from the Erie audience and then the final question at the end. But Remdesivir and other treatments for COVID-19, what have we learned in the last year and where are we today?
Yeah, so briefly, that graph I showed you about the biology of that innate immune response and the adaptive is really important for how we use treatments. You'll notice if you just think back to that, the virus came up and went down, usually by day 7. Remdesivir is an IV drug that's usually not given until day 10 or 11, well after the virus has been shut down in a large part by the immune system. So Remdesivir is not nearly as effective as it could be if it were given really early. The problem, it has to be given IV over 5 days, and you can't do that in the outpatient setting. So what we have instead is something called a monoclonal antibody, or there's several of them, and they're paired up, usually 2 antibodies in 1 infusion. And we give that as close to the time of onset of symptoms, and it works like gangbusters. And it's kept people out of the hospital. It's shortened the course of illness dramatically. We've treated well over 1,000 people in our outpatient setting. And the way that everyone on the call will know about this, that's precisely what Donald Trump got in the first week of October at Walter Reed. On that Friday, he was taken by helicopter, was given monoclonal antibody, and it was a game changer for him. Then I'd written an op-ed for the Washington Post where I said I saw him breathing hard on the South Portico. And I said, oh my goodness, I know what that's like. When you're trying to suppress the image that you're breathing hard and you can't suppress it, that's what he looked like. And I went through that, and I knew that I was sick for another 2 to 3 weeks after that. And I'm thinking, he's not going to be able to finish his campaign. Well, the monoclonal antibody from Regeneron, in his case, cut the illness down, and he was able to go on with his campaign. That was a miracle drug for him and for the rest of us.
So many wonderful comments. This is just one of them, Dr. Saag, from one of the Erie area residents watching tonight. Just want to say that your presentation was amazing. I have listened and read for hours throughout this crisis. I feel I learned and understand more tonight from this session than anything else. So
wow.
for that.
Well, that's so kind. Thank you.
Well, it's genuine. This is from another question. When does a child's immunity fully develop, especially if they are taking 6-month-olds maybe next year in terms of the vaccine? I think that's the question. So if you could elaborate on that.
Great question. The child's immunity develops over a significant period of time, but a lot of the immunity and the immune response is there. Remember, nowadays we give infants at the time of birth hepatitis B vaccinations, so they can work. I don't think we'd be giving it this vaccine any earlier than 6 months. Maybe not wait till, and maybe we'd wait until a year, but the immunity will develop. And 3 months is usually the nadir where the maternal immunity is pretty much going away and the child's immunity picks up. So I'd say that those are the key moments. But again, most of the reason to vaccinate a child is to get rid of these reservoirs of the virus that can percolate, develop the variants, and put not just the kid at risk, but certainly the parents, grandparents at risk.
As Ben had mentioned, President George W. Bush, who back in 2005 gave a major speech after having written the book on the 1918 pandemic, trying to put in place a government apparatus that would be prepared for a pandemic. Dr. Anthony Fauci, as you well know, your good friend, was part of that effort. Well, first of all, do you want to talk about that?
Yeah, prescience, right? I mean, we tried to prepare. And in fact, if I understand correctly, excuse me, the National Security Council had an arm of it that was designed to be responsive, and that was not available to us when this epidemic broke out. But I think that we'll be having it again. Very important that this public health is a big deal, and we miss it when it's not working well for us.
And so the question is, he will be in Erie. There will be hopefully an in-person global summit. And boy, it would be great to have you come to Erie sometime in the near future, because this has been such a terrific evening. But what is your sense about large in-person events with 1,000, 1,500 people in attendance?
I'm not a big fan of that right now. And I think the preliminary stuff I shared with you explains why I think that way. With only 60% of us vaccinated, that means 40% of us are still susceptible. And so you go back to that calculation of, if you have 100 people together, what's the probability that one person is infected? It's kind of high. You get 1,500, you're not only assured that one, you probably have 10 or 15 people in that crowd. And what I think, we're all so anxious, ready to jump on the way we used to live life, that I'm afraid we might be cutting some corners along the way. So I would take the CDC guidance and use it as a spark, as a stimulus for us to get vaccinated. And if you haven't been vaccinated, talk to your doc, talk to your friends, especially your doc. Have the doc go over this with you and talk about the benefits. I think they're clear from what I presented so far, but it's good to get reinforced from your provider.
Another question and another note of praise. Thank you, Dr. Saag, for an absolutely great program. Learning so much from you tonight. Thank you very much for sharing your insights. So you're getting a lot of love from the people of Northwest Pennsylvania.
Thank you.
You've been a doctor for many, many years, and you have a family. I mean, you know, when we were kids, you got the mumps shot. I just got the shingle vaccine. But why is there a strain in this country that has a hesitancy towards vaccines?
Well, there is a subset of our population who are anti any vaccine, and that's not new. And the concern is that it's damaging, but those individuals are a relatively small fraction. What we're experiencing now is something more powerful, more pervasive, and to me, more concerning in a way, because my interpretation is that a lot of it, as we've alluded to, is driven by emotion and is driven by a sense of being on a team. And that if the other team is pulling for this, then by God, I've got to be against it. And we got to get beyond that. One thing that I'd like to highlight, Steve, is that here's the way I look at public health. When you and I, or any of us, go to our doctor, and especially it's someone we've been with for a while, we have trust. And we know that when we see that provider sitting across from us and we tell them a problem, we know, number one, they're going to listen, they're going to react, and they're going to have our best interest at heart every step of the way. And hopefully they're being honest and explaining things thoroughly. In almost every case, that's true. Public health is no different, except in this case, the population is the patient and the public health official is the provider. And it's the same thing. There is no motivation for that public health official to do anything different than a doctor does for its patient. It's just doing it for a population. And so when we see very earnest doctors like Dr. Fauci or Dr. Walensky looking at us in the eye and saying, this is what we see, this is what we suggest. And we understand that this view may change as more information comes out. Witness the mask change of last week, when new data came and showed that people who are infected don't shed that much virus. So therefore, even if they have a transient infection, it's safe to be around others, even not wearing a mask if you're vaccinated. That's what we have to do. Reestablish that trust in one another, and we'll be much more efficient and effective in fighting this.
So as a follow-up to that from another participant, what about requiring vaccines to attend events, the so-called vaccine passport, even informal passports?
Yeah, I'm not heavily in favor of that, at least for events. I think we're going to see it for travel to other countries, a requirement, just like we do. If I go to places where yellow fever is prominent, I can't get in the country unless I have a yellow fever vaccine. I've got a little yellow card. I'm sure most of you do. You traveled overseas, you have your vaccines, you get your shots. COVID will be one of them, and we'll be required to show that. Where I think we all will see mandates, and I personally support this, is in schools. I think the teachers, students need to be vaccinated, because I saw a lot of cases percolating from middle schools and high schools over this past spring, fall, and into the spring, where principals, coaches, teachers became infected. And unfortunately, way too many of them died. And I think that's a national tragedy.
This is a very specific question. And again, the questions have been phenomenal. So you can just get a sense of how engaged the community is to your conversation tonight. This is a question from somebody who says, quote, if you have cancer and are not undergoing treatment, are your white cells busy fighting the cancer that one shot is okay, so that your cells can then fight the cancer as well as the COVID without being overwhelmed?
I like the question. Our immune system can walk and chew gum at the same time. And so it's not just, it's going to focus on one thing and something else gets ignored. The immune system works in concert. It's a miraculous system. It's amazing. And we just are scratching the surface of understanding it. But yes, your immune system can fight a cancer, and your immune system can be taught how to fight COVID. What we don't want to see happen, and I think we got to keep this in mind every step of the way, is that for somebody with a cancer to get COVID on top of it. If you think it's a struggle to have a response to a vaccine, the response to infection with COVID virus is devastating and potentially fatal. And so that's what we want to prevent.
I have two final questions. The one I already know the answer to, because I've asked you this during a C-SPAN interview, but I think it's a fascinating story. Your own arc of experience from AIDS to COVID to battling COVID yourself, and why this is your passion. Tell us the Michael Saag story.
Briefly, I got involved in HIV mostly through serendipity. It's too long a story to tell, but I basically started working in a lab, and we made some early discoveries that ended up being big. It was just luck. And that sort of hooked me on the idea of doing academic medicine. Started in an AIDS clinic and was just drawn by the patients and the stories, and really committed myself to trying to make HIV what it's become today, which is a chronic manageable condition with therapies that are fairly straightforward and not really that toxic, and people can live a normal lifespan and not spread the virus to others. So when COVID came along, it hit me literally, and I wasn't expecting to get infected. It was kind of an accidental exposure, and living through that, I learned a lot from my HIV patients that I applied. Number one is volunteer for research, and I did that from the third day of my illness. and started donating blood and that type of thing. The second thing is to be public with my story, because people can look at statistics, but they don't understand how it impacts people until you hear from the people who have been impacted. And the third thing is, I learned a long time ago by watching them vicariously of dealing with the fear of not knowing what the next day is going to bring. And I experienced that firsthand in the middle of the night, 8 nights in a row, as this thing came roaring back, night after night. I said, like Groundhog's Day. At 2 a.m, my oxygen levels would drop. I'm thinking, oh my gosh, I'm going to the hospital in the next 30 minutes. And I just hang on. But that fear of not knowing what's next is something that's impossible to describe unless you've been through it. And I'd seen a lot of patients tell me, and I was kind of sensitized to it, but I learned that lesson in a big way. So going through that, I obviously was sensitized to what COVID patients went through, but I also, this is something that why I went into infectious diseases in the first place, is to make a difference when I have something to contribute. And I think that's what we all do, no matter what walk of life we're in. We're trained to do certain things. And the thing that I've learned is that I always wonder, why does a firefighter go into a burning building? Well, it's because that's their job. In the case of a public health official or doctor, no one thinks twice. They just go and do, because that's what we do.
Well, and let me direct our viewers to go to the Washington Post, your incredible essay that you wrote back in March and April of last year that really brought national attention to what you do. And again, let me first say thank you, because you have been beyond gracious with your time and sharing your expertise. I have one final question. You can take as much time as you want, but I know I convey the gratitude of the people of Pennsylvania and those from Ohio and upstate New York who are watching as well. So thank you. My final question is moving ahead, because we have now dealt with a pandemic that has impacted every one of us in one way or the other. There isn't a single American that cannot say this has not touched them, whether not being able to see relatives or not going to work or dealing with the pandemic themselves and dealing with the illness. So what can we learn about COVID-19? And specifically, when we have Johnson & Johnson, Moderna, Pfizer working together, are there lessons that we can apply from this pandemic to deal with other health issues, other pandemics, or maybe even bigger issues like cancer? And again, take as much time as you like.
Thanks. That's a great question. I'll start with what we've learned. And what we've learned is what works and what doesn't work in terms of public health. And we've also learned the destructive forces of the politicalization of health policy. That is a really bad idea. And I even see in our state, but other states, where they tried to strip away the authority of a lot of public health officials because they disagreed just at a visceral level with what the public health authorities were doing, which is, of course, the right thing, but for political reasons wanted to strip it. I hope we learn not to mix politics with public health ever again. Hope we learn that. I hope we also learn not to assassinate the trusted voice. And we did a lot of that during this pandemic. And I think we paid a price for that. So please just trust as best we can. You trust the airline pilot. When you get on the plane, you believe that they've been well-trained and they know what they're doing. You put your life in their hands. That same thing is true of our public health officials. So they didn't get there by accident. They're well-trained and they know what they're doing. The other things, on a more positive note, we learned how science triumphs. And the actual use of science in a collective way to miraculously create this vaccine in less than 10 months, not only create it, test it, show that it worked, but have it produced in large quantities, such that when the vaccine was shown to work, it was available for distribution. Not quite as fast as we all wanted, but it was there. And that's a tribute to the science and to the public health officials and the last administration for having the foresight, Congress, to invest in the companies, Pfizer, Moderna, J&J, and a few others, to say, we're going to de-risk this for you. We're going to give you $1 billion, maybe more, and you start building your plants now, even though you don't know this is going to work. That's an important lesson. And I think also this whole notion of this mRNA vaccine platform that we've never used before, I'd guess that most of our vaccines in the next 10 years are going to convert to that. Perhaps the flu vaccine. Maybe we'll get this respiratory syncytial virus vaccine, maybe the AIDS vaccine ultimately. But that new platform is enormously important. And the key thing, just for the technical side, it doesn't require an adjuvant, which an adjuvant is a compound that you put in to a vaccine to stimulate the immunity as the antigen's given. Don't need that with an mRNA vaccine. It works just fine without all that. We learned a lot there. As far as predictions, I'll yield to Yogi Berra and say they're difficult, especially when they involve the future. But in this case, I will make a prediction that we will be dealing with COVID for quite a while. I would guess at least 8 to 10 years in some form or fashion, different pockets around the world, there'll be outbreaks. And we aren't going to eradicate this anytime soon. We will get better drugs. We're going to get oral drugs that we can take as soon as the first symptom appears and squash this thing. A Remdesivir, except given on day 1, not day 10. And I think that we'll have global cooperation, which we're starting to see now, distribution to the hot pockets around the world, the United States leading the way, being the vanguard for fighting this thing along with other nations. And I'm very optimistic that we can get this under control, although eradication of this is going to take a lot of effort. And it starts with us at home, ourselves getting vaccinated and shutting it down in our homeland.
One final point, and I just want to conclude on this note, and it's a line you probably heard, but my mom often told us that after the darkest storm is the brightest rainbow. My sense is that despite the horrific nature of this pandemic and the economic and health setbacks it's caused so many Americans, that there is a silver lining in all of this when it comes to, pharmaceutical companies, the government working together to try to find a greater good.
Amen. Agree completely.
Dr. Michael Saag, I cannot tell you how grateful I am on behalf of the Jefferson Education Society, and we'll turn it back to Ben Spagan, but on behalf of Dr. Furky Ferrardi and all of the people of Erie, Pennsylvania. Would you come up to Erie sometime?
Absolutely.
We'd love to have you.
I'd love to be there.
I'm in Washington right now, but I'll come up and join you. So
that'd be fabulous.
Much. Ben, I'll turn it back to you.
Thank you, Steve. And thank you, Dr. Michael Saag. We cannot wait to get you in Erie, Pennsylvania when we can safely do so. But a big thanks to our guest tonight, Dr. Michael Saag, the professor in the Department of Medicine, Division of Infectious Diseases, Associate Dean of Global Health, and the holder of the Jim Straley Chair in AIDS Research at the University of Alabama at Birmingham. Thank you for sharing your insights and knowledge with us here at the JES Digital Global Summit stage. And a big thanks too to Mr. Steve Scully, the chairman of the JES's Global Summit Speaker Series, for moderating tonight's lively and fact-filled and awesome conversation. And a thanks goes out to our entire JES team under the leadership of our president, Dr. Furky Ferrardi, and to the JES Board of Trustees under the leadership of our chairwoman, Joyce Savacchio, and to all of our event sponsors, Erie Insurance, Erie News Now, the Erie County Gaming Revenue Authority, WQLN Public Media, and the American Tapestry Project, and to our Global Summit event partner, the City Club of Cleveland. And of course, to all of you watching along at home, thank you for tuning in. These programs and discussions and the exchange of information and ideas would not be possible without you. Folks, for more information about the JES, including how to register for additional Global Summit events, which you see on your screen right now, please do visit our website, jeserie.org. There you'll also find videos of past presentations available to stream on demand and publications, including reports, essays, and timely writings, as well as information about other JES initiatives such as our Civic Leadership Academy and our Ramey Fellows program. And be sure to like us on Facebook, follow us on Twitter and Instagram, and subscribe to our YouTube channel. For the Jefferson Educational Society, I'm Ben Spagan. Be safe, be sound, and thanks for listening and learning with us.